All right, welcome everyone. We'll get started in just a few minutes, but for those of you who have joined, welcome, and we'd love to have you introduce yourself in the chat. Let us know where you're calling in from. If you've been to a forum before, or this is your first one, we always love to see who is here. I do see some participants and attendees that we've seen in the past, which is great. But yeah, love to see who's here. And we'll get started in just a couple minutes. Okay, for those of us, or for those of you just joining, welcome. We'll get started in just a minute or so. If you haven't yet introduced yourself in the chat, please let us know where you're zooming in from. I see several familiar names and faces. Thanks for joining again. And for those who are joining for the first time, welcome. We'll get started in just a minute and I'll kind of introduce the forum as well as our speaker so that you get a sense of um, how the layout of the next hour will be and encourage you to ask questions and engage in the chat as well. So we'll get started in just another minute. But again, good to see so many familiar names and faces and also a lot of new names and faces. So thanks for joining. I see some Cincinnati folks where Lisa is from. Okay, I was just talking to Laura Esserman. She is trying to get her link to work, but in the meantime, I think we can get started with some introductions. So just to start off, again, welcome everyone for our monthly Wisdom Community Forum. I'm Allison Fiscalini, and I'm the director of the Athena Breast Health Network and the Wisdom Study based out of University of California, San Francisco. But as many of you know, we have the Wisdom Study is nationwide and it's open to all women across the country, ages 30 to 74, who have never had breast cancer before. And we have recruitment hubs in different parts of the country, but UCSF is sort of our home base coordinating center. So we host these forums once a month on the last Monday of every month. This month, because of Memorial Day, we bumped it up a week for those who might be out of town. Um, and again, these forums are open to anyone, so please do share and invite your friends and family if you find this informative, and always willing to hear suggestions on topics for the next months. So please do share those with us. And again, if you haven't already shared where you're calling in from, please do. We love to see where people are from and if this is their first time to the forum or not. So with that, the
Just in
format,
time.
yes, the format for today is that these forums, we do want to hear from you. The whole point of this is to be able to share information, but also hear questions from our audience. If something isn't clear or there's an area where you want more explanation, please do add a comment in the chat. You can raise your hand. We'll have some time at the end for some questions as well. But we do ask that if you're not speaking, if you could please mute yourself and so everyone can hear the speakers clearly. We do record these so that they can be shared with those who aren't able to join. So we will send a link around afterwards where you can access the recording. And we'll also have a short post-meeting survey so you can share your feedback and suggestions for other topics as well.
Great.
Yeah, and just again, the whole point of these forums is that we come together as a community, both um, of women, of individuals, as researchers, as clinicians, as patients, to come together toward equity and better outcomes in breast cancer for everyone. The topics that we've had so far range from breast cancer risk factors to diet and alcohol and exercise to genetics. So there's a whole wealth of information in our past forums that are easily accessible in our YouTube channel, and we'll share the link with that. But this month, we have the pleasure of having Dr. Lisa Larkin on. We'll talk about menopause hormone therapy and breast cancer risk. And just a quick intro for Lisa. Um, so she's a board certified internist and also a nationally recognized expert in women's health and in menopause. She's the founder and CEO of Ms. Medicine, which is a national healthcare network of expert clinicians practicing across the US. And she's also the founder and executive director of Her Medicine, which is a nonprofit providing women's health education, clinician training, and advocacy. And Lisa is a breast cancer survivor herself, and I think has used that in a lot of the work that and her experiences and the work and the guidance that she gives to her patients as well. We were luckily connected with Lisa in the last couple of years, and she invited us to present the wisdom study at the National Menopause Society conference last fall. And from that, we've made wonderful connections to different menopause experts across the country. And a huge thank you to Lisa for inviting us and for giving us the opportunity to share wisdom across menopause clinician groups. So with that, I will stop sharing and we will launch it off with Laura Esserman, our founder of the Wisdom Study, starting the conversation off with Lisa.
Thanks so much, Allison. And, thanks, Lisa, so much for being on. I think we recently had Christine Menn on, and she was also talking about issues about hormone replacement and her view for both, from a GYN perspective and also from the perspective of a survivor. But I wanted to have Lisa on because I think what we want to do is have a slightly different perspective and maybe help the people in the forum really better understand that there's not a perfect answer. I think everybody wants an answer. What do I do? Yes, no. But medicine, of course, is more complicated than that, right, Lisa?
Yes.
And medicine is all, and making a decision about whether to intervene or not is often about making trade-offs, right? And it really depends on what is the problem that you're trying to solve. And we are actually had a meeting this morning. We're planning for our next Rise Up for Breast Cancer meeting, which is February 19th to the 21st. And what we're trying to think about is, okay, how can we rethink, the different periods of a woman's life where we might think differently if you're trying to do birth control and making choices about birth control pills in your 20s and 30s. You might be doing something else, whereas you might have different issues at the time of perimenopause, where I see it's very popular just to put everybody on birth control pills, you know, probably because of the thought, oh, well, there's no risk of cardiovascular disease. And then there's the whole issue about hormone replacement. And, once you're menopausal, what do you do in your 50s? And then what do you do in your 60s? Because your heart disease risks are different. So a lot of this is about the context. And a lot of it is about, do you have to do an intervention? Or, if you're perfectly fine, what are the things you should be trading off? And I think that was sort of where we ended it last time. There's a lot of confusion of like, well, what problem are we trying to solve? And where do we have opportunities? And, like with any intervention in medicine, right? There is no free lunch, unfortunately. When you toggle with one thing, it often affects other things. So I thought maybe, Lisa, you could maybe take a step back, maybe give us that sort of larger overview about why is this so controversial, and what are the problems that we're trying to solve? And I don't think anybody has to feel like, oh my gosh, I'm such and such, I have to have hormone replacement, or I could never have hormone replacement, or and even we talked about this before, just because you have breast cancer in the past doesn't mean you could never have hormone replacement. It really totally depends on the kind of breast cancer you had, totally depends on the symptoms you're having and what problem you're trying to solve. Right. And I often hear, this is the other thing, and I finally, Carol Fabian really illuminated me on this. So like, there's so many people saying, oh, well, I really want to prevent dementia. So I really want to have hormone replacement in my late 50s and 60s. And I'm like, where did this come from? Because it's just the opposite in the women's health study. But like, I'm like, I haven't been able to figure it out. There's a study from Mayo Clinic that if you have an oophorectomy in your 30s and you don't have hormone replacement, that's one of the things that can lead to an increase in Parkinson's and other things. That's a completely different situation than what most people are thinking about. And I think so much of this stuff gets mixed up, and it's really context dependent of like where you are in your life, right?
Yes. Well, first of all, before I jump into a whole long discussion, which I can talk about this for hours and hours, I want to say to everyone on the call, first of all, I'm so honored to be here. And I will tell you, I've been practicing menopausal medicine, from the dark ages, right? I'm an old clinician now who's been practicing for almost 35 years. And I will tell you, I have had the privilege of being mentored and guided, and I have watched Dr. Esserman over decades in the work that she's been doing. And she has really inspired me. And I think, wisdom is amazing. And it's really honored to be here to talk to this group. And I just want to give a big shout out to Dr. Esserman and her entire team for what she's doing, because from the very beginning, when Wisdom was launched, it was very clear that this was a really important study because, again, as you've just heard, I think you can't homogenize women. And what we know, and we've been trying to do, is homogenize all women who have very differing risks of breast cancer into a screening approach that is the same for everyone. And that fundamentally does not make any sense. When I talk to colleagues or in the community, I often say, if we were approaching cardiovascular disease the same way we are continuing to approach breast cancer right now, that would be like all of the internists in the world telling all of their patients just to get an annual stress test without doing anything to think about individual risk factors and ways to modify those risks. And I think the same thing right now is really happening when it comes to this whole very controversial discussion about menopausal hormone therapy, for symptoms, at midlife, and the pros and cons, and how does menopausal hormone therapy influence breast cancer risk. And I think it's not straightforward. I think there is nuance and complexity there. And one of the big things I think that's happened recently that I see is that because social media has exploded, and because on social media sound bites are really easy to put out there, again, I worry that we're kind of back to homogenizing messaging and really making it black and white. And as you just heard from Laura, it's not black or white. It depends on where you are in reproductive aging, your own risk factors, your baseline risk for breast cancer, your risk factor for other diseases that you have, what your symptoms are. And so it's an incredibly complicated, nuanced discussion. So what I've been seeing on social media, and again, because I think it's easy, and again, I'm a big proponent of menopausal hormone therapy in the vast majority of women, but that still to me does not translate into messaging that should say everyone should be on menopausal hormone therapy, and menopausal hormone therapy does not influence breast cancer risk at all, because I think that again takes us back to trying to homogenize all women when we know all women are not the same. And I don't know if that sets the stage correctly for you, Laura, but
Yes, I think that's exactly right. And I think that's what I want people to hear. And I think that even in wisdom, one of the reasons why we want to provide you information about risk is that might influence what choices you make, right?
Correct.
If your risk is extremely low and you've got a lot of symptoms, yeah, I mean, that's a different choice than if your risk is extremely high,
Right.
And, and you have mild or no symptoms, you probably wouldn't take it. Or if you still have bad symptoms, then you can think about Duvet or whatever it is. I mean, that there are, I think the point is, it's not one size fits all. That's everything that the whole idea of personalized medicine is, to try and understand risk and to try and understand what the interventions are and whether they help you or not, and what the alternatives are, right?
Yes. And I mean, again, I don't know what people would like with this format tonight, but I mean, I do have, I think, at least two
Good
cases,
primer.
examples of
Right.
kind of how I sit and think about this in the office with patients sitting in front of me to try to tease out for individual patients whether or not menopausal hormone therapy is a good idea or not. Because I think one of the things I'm seeing overwhelmingly in the office now is that the messaging really is getting out there. And I would love if anyone wants to drop in the comments or the chat right now whether or not I'm right on this, which is that now we've swung from when I started practicing in the dark ages, where all of my patients, this is in the 1990s, were on hormone therapy. Fast forward to the WHI in 2002, when the pendulum swung the other direction 100%. And we've now had 2+ decades of virtually no women being given hormone therapy at all. And I think those of us in the space really kind of understanding the nuance in the data. But the messaging that I see on social media now has taken us all the way back to the other direction now, with everyone virtually out there saying that all menopausal women should be on hormone therapy and that there's no association with breast cancer risk. And in my opinion, and I can show you, and this is controversial, and again, remember, you're listening to me and I'm not the gospel, but my interpretation of the data still is that that takes us too far the other direction in terms of homogenizing the information on social media, and that we still have to be in a place where we are having very individualized nuances discussions with patients one-on-one. And the problem, of course, is not enough doctors are trained in menopausal medicine. Primary care doctors in general are not trained in this at all. And so women are lost and I think very confused because of the differences in opinions out there.
Totally agree. So I think it would be great if you could just go over some basics and provide a framework and then some examples. And then I think we can talk about it because, there's increasingly new products, new things, depends on, are you trying to solve vaginal dryness? Are you trying to solve, hot flashes? Are you trying to solve, dry skin, in which case go get better skin lotion. Anyway.
So I will share my slides. I will go quickly. And for the participants, I'm happy to provide these at the end. And again, happy to take questions, and I'll go quickly so that we do have enough time for Q&A, if that's okay.
That would be awesome. Yeah, thanks.
So let me see if I can share here. All right, I'm going to back up. Oops, hang on. Okay, so I really want to talk about menopausal hormone therapy and breast cancer risk. This is the hot topic right now. So I don't have to preach to anyone on this call, but this is something that all women worry about. And again, the number is 1 in 8, but that is population risk. And again, doesn't really help us understand each of your individual risk on the call. So 100% of women go through menopause, and we know this is something that really has been neglected. Most women now are living 40 plus years beyond menopause. And although this is a normal transition of a woman through, her reproductive aging, it does not mean it does not have physiologic consequences for women, as well as now we know certainly economic impact. And that's one of the reasons that menopause is getting so much attention right now. And I would argue that women's health really has been ignored for a long time, and this has been ignored in research, and it's one of the barriers we have to really having a great answer to this issue about menopausal hormone therapy and breast cancer risk. And I can tell you that I've been in this space for 30 plus years, and unfortunately, I haven't seen much improvement. In fact, I've probably seen the other direction in terms of midlife women getting the appropriate care they need and deserve, particularly around menopause. And now with everyone being interested in healthy aging and a healthy lifespan. Dr. Rebecca Thurston, who's a good friend of mine, also previously on the board of trustees of the Menopause Society, I thought this quote was really great, is that one of the things that has also impacted why we let women suffer at menopause is that we really do have a high cultural tolerance for women suffering. And in fact, I saw a patient in the office today who was told by her clinician that she really, and I'm going to show you these cases, that menopause was natural and she just needed to suffer through it. So where we are today is menopause is having a moment, and still the biggest question that I hear from patients is, does menopausal hormone therapy increase breast cancer risk? Because when women are trying, midlife women, 50-year-old women are trying to make decisions about taking hormone therapy or not, unfortunately, they don't worry enough about their bones, and they're really worried about breast cancer risk. And I think, and you may be hearing things on social media that don't agree with me. And remember, I don't want to tell you that I'm the end all be all, but you're hearing that menopausal hormone therapy does not influence a woman's risk of breast cancer at all. And I think that that is too black or white. My opinion is, and believe me, I support menopausal hormone therapy use. Menopausal hormone therapy is great for the vast majority of women who have more benefit than risk, but that's not 100%. So in my case, in my opinion, the very black or white statement that it has no impact on risk does not take into consideration the individual variables of the individual patient sitting in front of me. So why do I think this discussion is so complicated? Because we're not considering a woman's baseline risk. Some women are at quite high risk, others are at low risk. We also haven't done enough, and we don't have enough data about the differing effect of different hormone regimens. Some women get to take estrogen only if they've had a hysterectomy. Other women take estrogen and a progestin or progesterone. And we know that there's differing effects on breast cancer risk. We also know they start at different times, they continue for different durations. And unfortunately, we don't have large randomized controlled trials beyond the Women's Health Initiative, which only looked at one formulation. And we probably are not going to have the same size trials again, looking at other formulations. And so there is really a data gap. And so what we're all trying to do is use the existing data to kind of really inform women. And I think there's gaps in that data. So what's the answer? Should you, if you're a midlife woman, take menopausal hormone therapy? I hear that messaging out there in the practice now that everyone's being told that they should be on estrogen and progesterone and testosterone. In my opinion, that is not a black or white discussion or black or white answer. And I have an individual discussion with each patient.
And you will, of course, tell everyone what they should do first is join the wisdom study.
Yes, and I do. I have my flyer I hand out all the time. Okay, 2 cases. This is Liz. She's 52. She's healthy. She's been postmenopausal for 2 years. She's having terrible hot flashes. Her mammogram's up to date. She has scattered breast density, so not dense. She has healthy lifestyle habits. She has a mother that had ovarian cancer at age 80, and her physician practitioner told her that she couldn't take hormone therapy because of the risk of breast cancer. And again, she should just live through it. A second patient, a little bit different, 56, 56, hypertension and high cholesterol, controlled on medication, also severe ongoing hot flashes. A mammogram 6 months ago was negative. She has extremely dense breasts, and she has a first-degree relative, her sister, with breast cancer at age 54. And again, her practitioner told her hormone therapy is dangerous and she should just get through it. But both Liz and Catherine are worried about breast cancer, but they're both hearing on social media that menopausal hormone therapy doesn't impact breast cancer risk and that they should be on menopausal hormone therapy for heart disease prevention and bone health and preservation of muscle mass and cognitive, prevention of dementia. And they don't understand why it's so confusing and their doctors are telling them not to take hormones. And so what do? Why is it so confusing? So if you want to read what I believe is the best single piece of consumer-facing information about menopausal hormone therapy, it's this article from the New York Times that Sue Dominus wrote in 2023. But we know that, again, menopause is a very significant time in a woman's life. And it's not just because they're done childbearing. It's because the abrupt hormonal changes of menopause are associated with huge physiologic changes. And all you have to do is talk to a menopausal woman who knows their symptoms and they know that their body is changing. But what they're often less aware of is that menopause is a time for very abrupt increase in cardiovascular risk. It's associated with increased change in lipids, elevated blood pressure. Often women have new insulin resistance and pre-diabetes. It's a time of very accelerated bone loss. And you may be hearing on social media now about the musculoskeletal syndrome of menopause, brain fog, mood disturbance, sleep changes, hair loss, skin wrinkling, and of course, weight gain. And all of these things are associated with the midlife transition of menopause. So just because this is a normal physiologic time doesn't mean that there aren't huge consequences, impact of that. And what I really say is that men and women age very differently. So men age much more linearly, and women have periods of time, especially at menopause, where it's basically like falling off a cliff. And if you talk to a woman as they transition through menopause, as I do day in and day out, women tell you what's going on. They obviously notice the physical changes. And again, what they don't really understand is all of the new risk factors that they have because of the loss of ovarian estrogen. And so hot flashes are the most common symptom. So 50 to 80% of women get them. There are racial and ethnic variabilities. Most women 85% of women will resolve their hot flashes within 5 to 7 years, although there's a lot of variability depending on race and ethnicity. But what you should know is 10 to 15% of women have hot flashes for the rest of their life, and they never resolve. The other thing to know, and primary care doctors often tell this to patients, which is that it's just a hot flash. Well, as a breast cancer survivor with horrible, persistent hot flashes myself, I can tell you that they are more than a lifestyle thing. They clearly impact quality of life. But what we also know is that in women who do have severe vasomotor symptoms, there's something different about them, in the same way that women who have very elevated breast density, for example, have a different risk of developing breast cancer. Women who have severe vasomotor symptoms or hot flashes really at all are at elevated cardiovascular risk. They have higher cholesterols, higher BMIs. We tend to see higher blood pressure, and we know that they have increased cardiovascular disease progression. It's also women who have them, it's also associated with increased bone loss. And so a hot flash is not just a lifestyle thing. Hot flashes are a marker of something we call autonomic dysregulation. There's something different about women who get them that places them at increased risk for other diseases. And so hormone therapy.
Wait, I'm going to stop you for a second. Is that true? Like what?
What do you mean? Cardiovascular risk and osteoporosis.
Oh, the hot flashes? Why? Because of
It's a marker.
reflection of more severe drop.
Yes. Women have more accelerated bone loss who have more severe hot flashes and have accelerated cardiovascular aging as measured by CAC and arterial stiffness.
So has that been correlated to estradiol levels? Do you know?
Not to specific levels, but it is well established across the transition. Like you can see more significant, again, I have some other slides of changes in coronary artery calcifications. You want me to keep going?
No, I'm just thinking.
So it really, and it's elevated blood pressure, and it's, again, I think no one completely understands it, but there is an autonomic dysregulation, an autonomic component to it that clearly, and even the other thing that's very well established is women who are having more severe vasomotor symptoms have increased fat deposition around their heart, again, which is a marker of more accelerated vascular aging.
That's interesting. So like in the new, we can circle back to this, but the new agents that work centrally to reduce
hot flashes, that's the big issue, which is right. We don't have any data about impact on cardiovascular risk, right? So we don't know yet if you control the hot flashes with not hormones, right, with other medications, whether or not you have the same benefit in cardiovascular risk reduction. It's really interesting. And that's one of the reasons
studied. I mean, again, what's the right cocktail? Is that
right?
A statin? Is it a this? Or if you're on a statin, does it not matter?
Right. We don't have 100% of the answers, but hormone therapy has been around for a long time, and it's the gold standard for treating hot flashes, sexual dysfunction, and we have great data about prevention of osteoporosis. The one thing I want to point out, and I had a new patient in to see me today who is now 52, but she had spontaneous premature menopause at age 43. And she was never offered hormone therapy. So she now came to see me because she had her first bone density after pushing her doctor to get a bone density. And her T-score is already minus 2.7. She already has significant osteoporosis and she's mad today, right? So one of the things to remember for everyone is that when we're having this discussion about menopausal hormone therapy and breast cancer risk, it doesn't include women who have premature or early menopause. All women should be given appropriate hormone therapy until age 50 or 51. And so my patient, the one that I saw today, really should have been given appropriate hormone therapy because clearly now she's behind the 8 ball with her bone health because she didn't get appropriate hormone therapy until age 51. When we're talking in these cases today, it's about patients who are 52 or 56, so natural age of menopause, and whether or not how we would think about hormone therapy for them.
Lisa, real quick, there's 2 questions in the chat. While I have this slide up, I think it's timely. One is to define hormone replacement therapy. And the question is, I use estrogen cream for vaginal dryness. Is that considered hormone replacement therapy?
Okay, so let me and again, you will hear the term hormone replacement therapy all over the place. We in the field now don't like to use hormone replacement therapy. We like to use menopausal hormone therapy, MHT or just HT, because we really want to get away from this concept that we are trying to replace women back to where they were with healthy, in their reproductive years when they were cycling. When it comes to vaginal estrogen, in my opinion, should be over the counter. So and I'll tell you why, 12 months of vaginal estrogen has the equivalent estrogen in it to 1 single birth control pill. Okay, the dosing of vaginal estrogen is like hydrocortisone cream you can buy over the counter versus steroids that you get for severe asthma or that you take a steroid oral pack, right? The dosing really matters. And you don't get detectable levels with vaginal estrogen. I would argue that vaginal estrogen is safe for everyone. And there's great data out there to support that. And I think even in breast cancer survivors, we've come a long way in understanding the safety in that group. So we don't if you're only using vaginal estrogen, we don't call that hormone replacement therapy at all. We call that local estrogen therapy.
Great. Okay, the second question in your example, the question is, what is a T-score?
Sorry. So and again, I'm sorry. It's hard to not talk in medical lingo, and I try, but I don't always succeed. So osteoporosis and bone health is really hard for patients to understand because it's not like knowing cholesterol or your blood sugar where you just get a number on a lab test. T-scores represent the standard deviation away from normal. So a normal bone density is a T-score of +1 to -1. Osteopenia is -1 to -2.5, and anything below -2.5 is osteoporosis. And that's very hard to understand. So I don't expect you all to remember that, but it's a way that we look when you get your bone density. It's a way that they use the information to score, and it is reported out as T-scores, which is standard deviation away from normal. So anything lower than -2.5 is osteoporosis.
Thank you.
Okay. So what we know is hormone therapy is not approved anywhere. Guidelines really don't say that all women should be on hormone therapy for prevention of chronic disease. And I do hear that that's still out there right now in the ether for on social media. But again, guidelines really don't tell us that. But let's go back to Liz and Catherine. This is not primary prevention. Both Liz and Catherine are having terrible hot flashes, and they're trying to decide about hormone therapy, but they're worried about breast cancer. And so hormone therapy has tremendous benefits. And as I said, I prescribe it every single day. And the patient that I just had today with the new osteoporosis, who's 52, who had premature menopause, I put her on hormone therapy today. She should have been on hormone therapy from, age 43. And I had a conversation with her about all of these things. What are the benefits in terms of her bone? And then we really looked at what is her breast cancer risk and and I'm going to show you an example of this. How did I explain to her what I believe hormone therapy may or may not be doing to her baseline risk? But hormone therapy really has benefits on the hot flashes that every woman get, insomnia, vaginal dryness, sexual dysfunction. It clearly in the studies reduces colon cancer, hip fracture, skin wrinkling, cataracts. There's great data about prevention of diabetes and preservation of body composition. And we know that women who take hormone therapy have improved quality of life. And so again, hormone therapy is not all bad. What we know though today is that very few women are taking hormone therapy. Now, this less than 5% does not include compounded bioidentical pellets that a lot of women, particularly in my community in Cincinnati, are getting. But still, we know even with women who are very symptomatic, where guidelines would say this is a really appropriate patient for menopausal hormone therapy, they're not being offered it at all. So we do know there's this disconnect between really women being prevented from getting hormone therapy when they're really appropriate candidates, and then where we're talking, which is how to have the nuanced discussion if you have a patient that has higher than average baseline breast cancer risk. What does the data really say about the impact of hormone therapy? And so again, this is a topic that's exploding on social media. Menopause is really having a moment. You can't be a 50-year-old woman and looking at Facebook or Instagram and not being fed a feed with all of this information. And I can tell you, I have tremendous respect for my colleagues who are physician influencers. I am not a physician influencer, but you can see these 8-10 people on the screen. And Dr. Men, I know, spoke a couple weeks ago, and she does a great job as a physician influencer. These clinicians are having huge impact on the messaging out there. And really, they are game changing the conversation around menopause and really trying to empower women to get better healthcare. The problem, I would tell you, is that not all of the information out there has been vetted. And just as Laura kind of alluded to, right, you can cherry pick teeny tiny small studies and then have a great headline out there. And when your followers are 3 million people, it really has a huge impact. And so this is really, again, I give tremendous credit to these physicians who like doing this messaging, again, but with good, sometimes there's a little bad with it too. And I think sometimes it's just very hard for consumers to figure out what's really good information and what maybe they need to double check. And one of the other things I would just say is, our professional societies, right? We're like the stuck in the mud, as we've been called, the old school doctors, and we aren't social media influencers. And if you look at all of our women's health organizations compared to 6 million, in total, we have 150,000 followers, right? So the impact that we can have as societies in terms of getting messaging out there to women is really much smaller than the social media influencers. But I want to switch gears quickly and just remind everyone that, again, one of the things that Laura has known for decades, and one of the reasons for the wisdom trial, is because we've been trying to say we should screen everybody the same. And the truth is, we know that every woman sitting in front of me in the office has different lifetime risk based on her reproductive factors, her biometrics, and her genetics, and that we shouldn't be screening them the same, hence wisdom. But let's think about that same thing when it comes to menopausal hormone therapy. My opinion is we shouldn't be homogenizing the information and saying that hormone therapy carries no risk, depending on what your risk at baseline is. And we don't have data to support that. So for our 2 patients, we know that Liz and Catherine, just based on what I told you, their family history, their reproductive factors, they have very different breast cancer risks. They're still both worried about breast cancer, and they both want to start menopausal hormone therapy. So in my office, what I do every single day is I try to understand a woman's risk and put her in one of these 4 categories. And it's not perfect science, as Laura would say, right? The tools we have currently available that I can use in clinical practice in my office to help me understand a woman's baseline risk are flawed and imperfect, and we need to do better. But it is a starting point for me to understand how to approach conversations about hormone therapy, never mind how to talk to them about enhanced screening or potentially about chemo prevention. And as Dr. Esserman mentioned, to think about options for what hormone therapy might be appropriate for them. And DuoV is something that I use regularly as well. But this is my goal for me in my office. I want to try to understand if my patient falls in which of these 4 categories. And we know that there's lots of things that increase risk, and I won't spend time on this because it sounds like you've had to talk about this at all. But remember, age influences risk significantly, family history, and then breast density outside of genetics is really the other thing that influences individual breast cancer risk the most. But don't forget about lifestyle. I don't think we've done enough in society with population to empower and educate women about the impact of lifestyle, education, diet, alcohol consumption, diet, exercise, maintaining ideal body weight, and how that influences risk. And I'm going to skip this quickly. And again, density is really important, and there's lots of messaging now on your mammogram. All women are being notified of their breast density and how that influences risk. What I just want you to know, though, is I am passionate about trying to figure out who my hereditary mutation carriers are, because we know that estimates are right now still only about 10% of individuals who carry hereditary cancer mutations have been identified. I am a huge proponent of population genetic testing because the cost has come down now. And I find mutations all the time in individuals, and that has an impact not only on the patient's risk of developing cancer, but on their family as well. And then the other thing is I do this risk modeling because what we know is that about 1 in 4 women sitting in my office, when I do the risk modeling, they hit that threshold of above a 20% lifetime risk, even if they don't carry a genetic mutation. And that's, again, the woman that I want to identify, because I want to talk to her about enhanced screening guidelines, but I also want to have a different conversation with her about menopausal hormone therapy. And so I hope for all of you, you're participating in the wisdom study. So Dr. Esserman's helping you understand your risk. We're learning about risk-based screening guidelines. But this is what I try to, get my patients in my practice to understand is, have a sense of not just worry about this 1 in 8, but know if their risk is actually substantially higher or lower than that risk. And so if I tell you our 2 patients, when I do the modeling that I do in my office, and I use something called the Tyrer-Cuzick version 8, her lifetime risk is 12%. We consider her average risk. And Catherine's lifetime risk is 23%. We consider her elevated risk. So again, both of these women have different risk of developing breast cancer, how do I have a conversation with them about that? So I do this, right? How do I think about the data when it comes to hormone therapy on their individual risk? And it really all comes where all the controversy comes from is the Women's Health Initiative, right? So the Women's Health Initiative, everyone today wants to throw out the study, and I don't want to throw out the study. I want to understand the study and use the data as best we can to inform women. There are no question that there's problems with the study, especially because the most of the women enrolled in the study had high cardiovascular risk. They were older. They were quite far from menopause. Not very many of them, only 12% had vasomotor symptoms. And so we aren't talking about the patients that I just presented to you. The other big thing is only one form of hormone therapy was studied. And we now don't use Premarin and Prempro, which is conjugated equine estrogen with a synthetic progestin, as often anymore. And so you can't take this data and apply it necessarily to the woman sitting in front of us. And we have to understand how to do that. But we have to learn something from it because this is the messaging that's out there. And when it comes to breast cancer, what was messaged in 2002 when that data came out was a 26% increase in breast cancer if you took Prempro, right? The conjugated equine estrogen and medroxyprogesterone acetate. And women heard that and thought 26% increased risk of breast cancer, that means 1 in 4. If I take hormone therapy, it's going to be a 1 in 4 chance that I'm going to get breast cancer. That's not what the data said, but that's what women heard because of the way it was promoted in the media. And the study, frankly, that messaging led to the boxed warning that is terrifying on all estrogen-containing products. And my argument with the boxed warning that the FDA has is that you took data from a study that's only looking at one type of hormone therapy, and we are now applying it to all types of hormone therapy and all formulation. And we don't have data to say that that's correct. And particularly, this same boxed warning is on vaginal estrogen, which I can tell you there's no data that says that this applies to vaginal estrogen. And I'm going to skip these just to go.
Well, and I think it's actually, but this is the whole thing about absolute risk and relative risk. So, if you have a 12% lifetime risk and that increases your risk, that's a 25% increase over that. I'm going to go from 12 to 15%. But if you 32%.
I'm going to go through that. I'm going to show you exactly how I talked to that. So this, if we look at the studies, what really came out is that the one arm that had the CEE plus MPA, the Prempro, had that 1.24 relative risk. That's the 25% increased risk. What is getting all the attention now is the CEE, which is Premarin, which is conjugated equine estrogen, which is not the same as estradiol, had a reduced breast cancer risk. And so a lot of the messaging on social media is to say, see, estrogen does not cause breast cancer. It's the MPA in the other arm that causes the breast cancer. I would argue, though, CEE and estradiol are not the same. And just like we can't continue to niche formulations in there and make blanket statements, because I think CEE probably has properties that it's acting like a SERM, which is why the breast cancer risk was reduced in that one arm. But again, back to Laura's point about how I actually talk to a patient, because that gets too complicated. So this is what I say. The biggest risk of having breast cancer is being female and having breasts. None of us are at zero risk of developing breast cancer. If I take 100 women and I follow them from age 50 to 60, and they just become menopausal and they just get older, across the population, 3 of those women will develop breast cancer. That's 3 cases of breast cancer in 1,000 patient years. If I take another 100 women and I put them on Prempro, the one product that was studied in the WHI, and I follow them for 10 years, 4 women get breast cancer. So it's 1 extra case of breast cancer, which is that 25% increase, but it's 1 extra case of breast cancer in 1,000 patient years. It's small. So it's not 1 in 4. And that's what I try to start with as a baseline understanding that, again, your biggest risk of developing breast cancer is understanding what your baseline risk is. And then how do we talk about hormone therapy? And the guideline from the Menopause Society really says the preponderance of data does not show an additive effect of adding hormone therapy to your underlying baseline risk of developing breast cancer, right? So providing some understanding that the impact of hormone therapy is small. And when I talk to patients, the impact of drinking alcohol every day is higher than the impact of hormone therapy. The impact of not exercising and being overweight is higher than hormone therapy. So we have to kind of put it in perspective for patients.
Well, I would also say is that, we decided that all estrogen had to be combined with progesterone because of the risk of endometrial cancer, which, tamoxifen and estrogen alone also have a black box warning, but that risk is like 1 in 100. That's like a 1% increase. And honestly, the one thing the Women's Health Study showed is if you were on the combined hormone replacement, the kinds of cancers you got were not just small little shoplifter cancers, that they were more significant, including node positive. So if I were going to take something, I would put an estrogen patch on rather than have combined hormone replacement. So of course you don't necessarily have to make those choices, but I think that's another thing that people don't think about.
100% agree, because again, I think what's happened, we've used the WHI to translate to all formulations and all regimens and all dosing in all people. And there's just no way to translate that data that way. And this is what's out there. And many of you on this may be hearing about this. So again, Avram Blooming is a very well-respected physician. He's really out there now on social media with a lot of data. I've read this book. It's a very respected book. And he really takes a very hard line that the data is just completely flawed and that estrogen does not cause breast cancer, has no impact on breast cancer risk. And the truth is he makes some really compelling arguments in the book about that. I personally would tell you though, and I'm going to give you some examples of why I think needs to still be more nuanced. But there's a lot of people in his camp and really kind of agree with his approach. And again, and messaging on this. I just, again, don't think we have enough data, in my opinion, to feel as black and white as he does about this topic and many others. So why am I not able to just sit here and say estrogen is not associated with any increased risk of breast cancer? And I'm going to pick a couple things that I think about. It's the same thing as I said, the way we thought about doing mammograms, right? All women have breasts, all women are at risk of getting breast cancer. We should just screen them all the same. Well, that doesn't make any sense. I think, again, as I mentioned, when we look at the WHI and the argument that clearly estrogen reduces breast cancer risk in that one arm of the WHI, I think we're lumping estradiol that we're using now with CEE, and I don't think we can do that. We have much less data about the impact of estradiol on breast cancer risk compared to CEE. The other big thing, and I actually really talked to people involved in the WHI to really say, do we know the women randomized to the hormone arms, do we have any sense about their breast density or their baseline breast cancer risk? And we don't. And we have no data about that, because my belief is, and I don't have this data, and I was told it would be too expensive to do, if we went back and actually looked at the entire group of study participants and we actually stratified them based on their breast density and their baseline breast cancer risk, I bet we could find out whether or not there's differing impact of at least Prempro on breast cancer risk in women, depending on their baseline risk, but we don't have that data. And then I hear a lot out there on social media about the pregnancy argument that if breast cancer, if there was a risk of breast cancer related to estrogen, that pregnant women would have high rates of developing breast cancer. And I just don't think that we have enough data to use that argument, right? Because during pregnancy, there's lots of other estrogens that are circulating. We don't really know the impact of estriol. I don't think it is very clear cut. And again, I think we also have lots of data about the benefit of anti-estrogen therapy in breast cancer survivors showing reduced recurrence risk. And so again, and in fact, for primary prevention, you drop the chance of getting a contralateral cancer by half. Right. So
it can't be,
it can't be so black and white.
Correct.
So how do I talk to my patients? And I will end here, and this is quick. So Liz is sitting in front of me. She has hot flashes. Her baseline risk is 12%. Now, I didn't want to complicate it by talking about her bone health, but this is how I think about her. She's miserable with hot flashes. She has average breast cancer risk. I sit there and tell her it's not zero. You have breasts. Your risk is average. It's not high, but it's not zero. You have a low risk of cardiovascular disease. You have healthy lifestyle habits. Menopausal hormone therapy is good for you. I actually think you're a good candidate for hormone therapy. It's also going to help your brain, your bones, help your sexual function and your sleep. And maybe, to your point, Laura, worst case scenario, if I was using Prempro, which I'm not, your baseline risk might increase from 12 to 14%. But you're getting all of that other benefit: cardiovascular benefit, bone benefit, sexual health benefit, cardiovascular risk reduction. Like, how do you weigh that? And that's how I put it for her. And then I have Catherine, whose lifetime risk is 23%.
Can I, before you get to Catherine, would you recommend Duvet for this person?
So that I would use as an option, absolutely. But I would tell you the next Catherine is the next one is who I really would talk to about Duvet. In her, I probably, because I use mostly transdermal and I use estradiol. And the reason I do it that way is, again, because of avoiding first pass hepatic metabolism, and because I can often get away with good symptom control for hot flashes with lower doses, right? So they don't bleed as often. And again, is that right or wrong? I don't know, but typically this patient I would put on bioidentical estradiol and patch transdermal and progesterone. But Catherine's baseline risk is higher, and she also has high cardiovascular risk. So how do I think about her? So I say to her, your risk of breast cancer is high. We have to be really, really thoughtful about your lifestyle. We have to be screening you with enhanced screening. You need to be thinking about alcohol and exercise and diet and weight management. You need to be doing that for both breast health and for cardiovascular risk reduction. And we need to be really fastidious about this. But you're symptomatic with terrible hot flashes. So how do I think about that in her? If I use the same math about the risk, her risk goes from 23% to 29% if I was using Prempro. And this is where I need the data from Dr. Esserman's studies that are ongoing to really look at Duvet, because I think it's not that if I use Duvet. And in her, this is a patient that I likely would offer Duvet, again, with limited data about potentially reducing the risk of her breast cancer, or at least not increasing it. But again, it's kind of a data-free zone. We don't have tremendous data about it. And
But if you lived in San Francisco or Boston or Kansas City, you could go on the Duvet study.
I know. I would like to. And I will end just by saying next on June 4th. So Amy Commander and Miriam Lusberg, medical oncologists who work in the survivorship space, are going to be doing a consumer discussion on my Her Talks, which is also free, 8 to 9 p.m. Eastern on June 4th, if you want to talk about this topic in breast cancer survivors. It's a little bit different, and I will stop sharing there.
Well,
Thank you, Lisa.
I'm looking at some of the questions here, and Patricia says she's ready to move to Cincinnati just to get better care from you.
Oh, that's thank you.
Parisa actually makes a very good comment. How do you know? She's been on baby Tam for a couple of years. So how does she know that the hot flashes or the mood swings, how do you know if that's tamoxifen or menopause? It's an excellent question. Best way to do that is to take a drug holiday and find out if a month goes by and you're still having all the symptoms, it's probably much more likely to be related to menopause.
Yes, and Laura, I would love your thought about that. I mean, I can't see who asked that specifically, but I've been on tamoxifen for 10 years now, and I have terrible vasomotor symptoms, and I've done multiple drug holidays along the way. I've also tried Duvet along the way. And the truth is my hot flashes are not very different on or off tamoxifen, interestingly enough. And I think that is the data, which is it's not really well correlated. And Laura, I don't know if you want to speak to that at all more specifically.
Well, I mean, there are some people who definitely have hot flashes that are related to the drugs, no question. But, I mean, part of the problem is a lot of people get breast cancer right around the time they're going through menopause, and it's very hard to distinguish one from the other, or it can exacerbate it. And so you have a drug holiday, you can sort it out. I will tell you that I saw something yesterday that I was very excited about, and this was a new tool that you might be able to read off of just a simple H&E slide, where you could really predict if you've got that long-term risk where you're at risk after 5 years versus whether your risk is really done at 5 years and you don't need to do it. Another thing that we can use sometimes is you can go back and look at the original tumor and look for a molecular profile, which we kind of established was looking at an ultra low risk. So the 70 gene test or the mammoprint can tell you, are you high risk, low but not ultra low, or ultra low? And it's the low but not ultra low that have that long tail of risk. And hopefully maybe this new tool from Keras could also tell you that. But that would make, I think, such a huge difference. And if you knew that was gone and you knew that you weren't at risk, you would take Duvet.
For sure.
Like a hands down, right?
Yep.
So sorry, may I ask something really quickly? This is Patty, so I really appreciate all the discussion. Seeing that slides from at the beginning when hot flashes can correlate with other health diseases, that sparked the question in my mind. And I am going to be off of baby tam soon in August. My 3 years is over. But I am now a little bit concerned about all those other diseases that might, because I have very high hot flashes. Also,
Right. Again, right. We don't know. So all women go through menopause, all women lose estradiol and have low estradiol levels after ovarian function ceases. Not 100% of women have hot flashes at all. And when we look at the women that do have them, it's about 30% have severe, 30% have moderate, 30% have mild. And we don't really understand, and it has to be SNPs and genetics and something else, why there are the women who have the severe ones. And again, I would tell you, don't panic about it, right? Which is, if you have good lipids, you're not diabetic, you don't smoke, and you are watching your cardiovascular risk factors, I would be happy with that. And again, not worry too much. If you had preeclampsia with pregnancy, your lipids are high, you also have pre-diabetes, those other cardiovascular risk factors, then those are patients that I do something called the coronary calcium score on, where I'm trying to look at other advanced lipid markers, trying to identify those patients who are really much higher cardiovascular risk to intervene early. But don't panic. It's not 100%. Again, it's like understanding, and I get migraines as well. So migraine sufferers are also at higher cardiovascular risk. So I believe, and I actually was talking to one of my cardiology colleagues about this, is, we haven't put together migraine people and vasomotor sufferers and how this all ties into cardiovascular risk, but it clearly has something to do with this whole autonomic dysregulation.
There's actually a cardiologist here who's very interested in the cardiac effects from breast cancer treatments, who's super interested in this. And, maybe we'll have the opportunity to look at this in the wisdom study, because we're now looking at the polygenic risk, this kind of, you get like 1 million low pass whole genome. You can look to see how to correlate the two. But there are ways in which you can look at it. If you have family history of stroke, or you have a family history of high cholesterol, or whatever it is, that you can optimize. These are the same conversations you have about statins. And there's great data that show that if you are at higher cardiovascular risk, it's probably not the estrogen, but taking a statin would be super important. That there are lots of things you can do. There's also and we don't know, there's a new class of drugs, that like medicines like Vioza, and another one. These are kind of a new class of what they call selective
NK3 inhibitors.
3R inhibitors, or are antagonists, or that directly block the, the pathway that triggers vasomotor symptoms in the brain. So we don't know whether that would help you or not, or whether you're just covering up one of the symptoms. But there are, again, this is one of the reasons why I think all of us should advocate for another women's health study and really try and think about, well, what questions can we ask? How do we start gathering the data? Because without gathering any of the data, who can give anybody any answers,
I know,
right?
we can advocate.
And, this is also this idea of this medicine that I'm talking about. Unfortunately, it's owned by Pfizer, but it's nearly off patent, so they're not very interested in studying it. And it actually has one of the most potent breast cancer risk-reducing compounds from the tamoxifens and the AIs and the SERDs and all these things, but it's combined with a little bit of estradiol. So and my colleague Carol Fabian is studying this. Then I'm participating in her study of looking to see whether this is reducing risk and whether it's reducing breast density. I mean, so far her data suggests it is, but that's why we're trying to test it. But that also might be like something that's really good for people. Will that fix all those cardiovascular problems? We don't know, but I think that's, it would be great to have this kind of investment in science. I have to say that, I hope everybody is going to be putting pressure on every elected official they know to support investment of science and knowledge. That really helps people make better decisions. I see Scott Wiener has a bill to try and maybe have California make up for some of this by investing, put a big fund in that could rival NIH for putting some of this money into areas that we need to study, like this. It's just too bad that we don't, that's how we learn. We can't give people better information if we,
Don't have data.
if we don't have data.
Yeah.
I'm looking to see other questions here where I know we're over time, but.
Yeah. And while you're looking, Laura, just a big thank you, Lisa, for joining us and for such an informative discussion. I know there are probably more questions that we can try and get to and answer offline. And we will definitely send a link out with the recording. And Lisa did say that she'd be willing to share her slides as well.
I put my email in the chat.
Perfect. Too. Excellent. Excellent. Yeah, so huge thank you. I know, like you said, menopause is having a moment and there's so much information out there, and appreciate you acknowledging that, the information that may be out there is not always accurate, or there's always two sides to every story, and there's more data that we need to really get to an answer and get to more clarity, and nothing is black and white. So
yeah. So the question, so Jennifer Martin said, so the second treatment we were talking about was it Duave that you were asking?
Yes.
This is a medicine that is a combination of benzodiazepine, this inhibitor, this risk-reducing medicine, plus a little bit of estradiol. And then recommending for the person who had high blood pressure and cholesterol, for sure you're going to want to be looking at statins and antihypertensives and getting the calcium score, doing the same thing. I mean, cardiology is ahead of breast cancer in their ability to look at, risk assessment, but there's tons of good data on that. Right, Lisa?
Yes.
Yeah. So
Marianne, I just want to answer, if you thought I was saying that all women didn't need to get mammograms, that is absolutely not true. Everyone needs to get an annual mammogram. It's just that we know
everybody needs to join the wisdom study.
And everyone needs to join the wisdom study, but I'm not throwing mammograms out. It's just mammograms aren't a perfect test, and I would love to be doing more for prevention, not just screening for early detection, but also that, again, we could have better informed screening guidelines based on risk, which is what wisdom is doing.
Stay tuned, more on that soon.
Yeah. So with that, I think we'll wrap for this evening. Our next community forum is on June 30th. The topic is to be determined, but will likely be an overview of our updated risk models that we're using in Wisdom that now incorporate BMI, menopausal status, and just giving everyone an overview of what those models look like. And if you've been part of Wisdom, what might change about your next recommendation with this new model. So stay tuned. Please do fill out that evaluation. And again, huge thank you to Lisa for joining us. You are a wealth of information and really appreciate not only you being on this forum, but also your support of Wisdom and your referring your patients and your colleagues to the study as well.
Thank you. Nice seeing everyone. Thank you so much.
Thanks, Lisa.
Thank you. Have a good
Talk to you
evening.
soon, Laura. Thank you.
Bye.
Bye.